We've got a clinical case. Let's go. Be careful. A 28-year-old man presents with a one-year history of chronic low back pain. He describes the pain as a dull ache that is worse in the morning, with significant stiffness lasting over an hour. He knows that the pain improves with exercise and worsens with rest. He also had a recent episode of painful red eye, diagnosis and anterior uveitis. And genetic test is possible for HLA-B27. Which of the following is the most likely diagnosis? Give me options. Lumbar disc herniation? No. Osteoarthritis in the spine? No. Rheumatoid arthritis? No. Ankylosing spondylitis? That's it. So this is a textbook presentation of ankylosing spondylitis, a form of inflammatory spondyloarthropathy. Every clue in the vignette points directly to the diagnosis. So why ankylosing spondylitis is the correct? Let's break down the classic features. Patient's profile. So ankylosing spondylitis classically affects young man, typically under the age of 40. Inflammatory back pain. The patient's pain has the hallmark features of inflammatory but not mechanical back pain. This is the single most important diagnostic clue. Insidious onset. Not from an injury. Worse in the morning with prolonged stiffness. Improves with activity and exercise. And worsens with rest. So classic. Extra-articular manifestation. Anterior uveitis. Inflammation of the anterior chamber of the eye is the most common extra-articular features of ankylosing spondylitis, and its massive clue. And finally, genetic marker. The strong association with HLA-B27 gene is another key piece of confirmation evidence. So why other options are incorrect? Lumbar disc herniation. This causes mechanical back pain, which is the opposite of inflammatory pain. It's a typically acute, often radiates down the leg, sciatica, and worsens with activity while improving with rest. And osteoarthritis of the spine. This is a degenerable wear and tear arthritis that also causes mechanical back pain, worse with activity, better with rest, but it typically affects older individuals, and morning stiffness is usually brief, less than 30 minutes. And rheumatoid arthritis. With rheumatoid arthritis is an inflammatory arthritis. It classically affects the small peripheral joints, hands, wrists, feet, in a symmetric pattern, while it can affect the cervical spine. It almost never involves the lumbar spine in the way ankylosing spondylitis does. So high-yield takeaway, the key to diagnosing ankylosing spondylitis is recognizing the pattern of inflammatory back pain. So improves with exercise, worse with rest. In a young man, often accompanied by extra articular signs like uveitis and positive HLA-B27. Okay, stay blessed.